Good morning. My name is John Hellerstedt. I'm a pediatrician by training and experience. I'm also now the Commissioner for the Texas Department of State Health Services, and it's my great honor to be here, especially with Dr. Lisa Hollier, who is the chair of our state's Maternal Morbidity and Mortality Task Force. Both Dr. Hollier and I are very appreciative of TMA's forward thinking to promote and advance maternal health in Texas through this special Maternal Health Congress. Please know that both DSHS and the task force share your commitment to maternal health. Our task force is charged with studying and reviewing statewide data trends on maternal mortality and morbidity, with a focus on how this information can be used to inform efforts to improve maternal health and safety. Simply put, we want to have actionable data and put it into play. Dr. Hollier will first highlight the statewide trends, and I will then outline the public health initiatives now underway to improve maternal health and safety. More specifically, on completion of our presentation, you should be able to describe the challenges and barriers related to that are causing increased maternal mortality and morbidity in the state, describe the population health disparities in maternal health, describe and critique evidence-based quality initiatives to improve maternal health, identify state agency resources for access to prenatal, maternity, and interconception care, and identify strategies to screen, refer, and treat substance use and abuse during and after pregnancy as we discuss HHSC's women's health, behavioral health, and Medicaid client programs. And I'm going to turn it over now to Dr. Hollier.
Thank you. Thank you very much, Dr. Hellerstedt, and thank you, Dr. Cardenas, again, for bringing all of us here together today to address such an incredibly important topic for the health of women. As we do at each of our task force meetings, I would like us to take a moment of silence for the families in Texas who are forever impacted by the loss of a mother. Because accurate and actionable data is so incredibly important to the implementation of our best solutions to address the problems of maternal mortality, the Department of State Health Services is analyzing significant amounts of available data. And what I would like to do this morning is to present to you some of those important statewide trends. Here we have a table that illustrates confirmed maternal deaths and puts those deaths on a timeline to help us understand what the causes are of these deaths and when the deaths are occurring. First, I'd like to address the data set. This is a data set that contains maternal deaths that have been matched to live birth or fetal death certificates within 365 days. So we do in fact know that each of these women have been pregnant within 365 days of their death. The causes then are those causes that are reported on the death certificates. And what you can see is a total of 382 deaths in the time period from 2012 through 2015. The majority of these deaths, in fact 60%, have occurred after 60 days postpartum. So they're occurring within 60 days up to that 365 days postpartum. The most common causes are drug overdose and cardiac events. The drug overdose deaths, as you can see from this slide, are primarily occurring more than 60 days postpartum, a total of 49 deaths over that time period. Other important contributors to maternal mortality include hemorrhage. As you can see, the hemorrhage deaths are occurring in a different time frame. The hemorrhage deaths are those direct obstetric causes, and these are happening either during pregnancy or within that first 7 days postpartum, the time when a woman is most likely to be still within the hospital. Cardiac events are also a leading cause of death, as I mentioned, and these events also are happening either while pregnant or during the first 7 days postpartum. Finally, hypertension deaths or deaths related to preeclampsia and eclampsia, again happening more commonly in the first 7 days. So direct obstetric deaths occurring in the time frame closest to the delivery. Because drug overdose deaths were the most common cause in this cohort of confirmed maternal deaths, the Department of State Health Services did a detailed analysis specifically on these deaths, these 64 drug overdose deaths. And what they identified was that 3/4 of the deaths involved the use of multiple substances, and nearly 60% of the deaths involved an opioid. When they did an analysis looking at the demographic factors that were associated with drug overdose deaths, they identified that Caucasian women were more likely to have a drug overdose death, and women who were over the age of 40. Also, women who had Medicaid at the time of delivery and who lived in urban counties rather than rural. The two areas of the state that were most commonly affected were the Dallas-Fort Worth area, which is Public Health Regions 2 and 3, and then Region 1 in the Texas Panhandle. In order for us to formulate better strategies for prevention, it's important that we understand the demographic characteristics that place women at higher risk. The rate of maternal death per 100,000 live births was calculated for a variety of different demographic characteristics for the 382 confirmed maternal deaths that happened between 2012 and 2015. And what you can see here clearly is that African American women with a rate of 42.6 per 100,000 are at significantly increased risk compared to women of other races and ethnicities. Women over the age of 40, our older women, are also at significantly increased risk compared to their younger colleagues. The death certificate data that we have does not have ideal markers of socioeconomic status, and so we've used several different measures as proxies for socioeconomic status and identified that unmarried women, those whose highest educational degree is a high school diploma, and those who were covered by Medicaid at the time of their delivery are at higher risk for maternal death. Other factors are also important contributors to maternal death. We talk a lot about the health of a woman prior to a pregnancy. In the analysis of these deaths, looking at associated conditions that could help explain or could contribute to an increase in the risk of maternal mortality, similar to other analyses that the task force has previously done, we identified that obesity is a significant risk factor for maternal death. The presence of diabetes and high blood pressure also significantly associated with increased rates of maternal mortality. Smoking during pregnancy, a very important association with mortality. Finally, late entry into prenatal care, similar to our previous analyses, also associated with increased risk, and cesarean delivery associated with maternal mortality. For cesarean delivery, it is not necessarily the delivery itself, but oftentimes many conditions that are associated with maternal death are themselves associated with cesarean delivery. Let's take a quick look in depth at rates of pre-pregnancy obesity. What we see as we look at obesity, African American women were more likely to have pre-pregnancy obesity than women of Latina or other ethnic groups. We see a significant increase, mostly in the largest increase in the other group, but also an increase of about 30% for Latina women. The increase among African American women is actually less than their colleagues. Taking another look at two other medical conditions that we talked about that are associated with an increased risk of maternal mortality: diabetes and hypertension. And you can see that overall rates of hypertension and diabetes also increased over the last 10 years. Diabetes was more commonly identified in women in other ethnic groups women who are Latina were the second highest group for diabetes, again, with rates increasing over the last 10 years. Hypertension was more common among African American women, and you can see the increases over time for all women. So both diabetes and hypertension, along with obesity, increasing for Texas women over the last 10 years. But good news, right? We said we've got a lot of serious things that we're talking about this morning, but there's some really good public health news. Rates of smoking have declined significantly across all groups of women. Caucasian women are the most likely to be smokers during the pregnancy, African American women second, but you can see significant declines in smoking over time, which is good news, seeing the strong relationship with maternal mortality. Prenatal care is incredibly important. I want to emphasize, however, that the health of a woman prior to her pregnancy is incredibly important. We cannot expect that in the 9 months of pregnancy, we can change her entire lifetime of social risk and medical risk. However, it is important for a woman to get into early prenatal care so that she can be evaluated, those conditions that put her at risk identified, and that risk mitigated by the different interventions that we can put into place. What we see here is that Caucasian women are more likely to enter into early prenatal care, and among the groups evaluated here, African American women were least likely to enter into care early. One of the important findings from this work is that this is from the Pregnancy Risk Assessment Monitoring System, and these women are asked about entering care. And one of the questions that they're asked is whether they got care as early as they wanted. About half of women reported that they got care as early as they wanted, even when they were getting care outside the first trimester. I think this gives us an opportunity to think about the types of interventions that we could put into place to help women understand the role of prenatal care. And certainly we understand that there are tremendous access issues for women entering prenatal care in the first trimester, and those things must be addressed as well. We've talked a lot about the role that behavioral health disorders play in maternal mortality. And what I'm presenting to you here is the rate of diagnosed depressions per 1,000 hospitalizations that are pregnancy related. And you can see here that the overall rate for Texas, about 10% of women have depression diagnosed in a pregnancy-related hospitalization. More common among Caucasian women than women of other groups, but clearly a common problem, 10% of women. Looking at this information another way, we're going to go back to that pregnancy risk assessment monitoring system. What this means is women who reported that they were feeling either depressed or hopeless after their baby was born. And we can see overall Texas rates at about 13.8%, more common among African American women and women of other groups, as you can see here. We know that for every maternal death, there are 50 to 100 cases of severe maternal morbidity, significantly more common than maternal death. When we use these specific ICD codes that have been developed by the Centers for Disease Control and Prevention to identify severe maternal morbidity, it gives us an opportunity to track those rates here in Texas and to track and compare our rates to other locations or other states across the country. Some examples of severe maternal morbidity include hemorrhage, or the way this is coded is transfusion of 4 or more units of blood, eclampsia, emergency hysterectomy, thromboembolism, the need for mechanical ventilation. So you can see that these are all significant complications of childbirth that can have not only short-term but long-term health effects for a woman who has these complications. So let's take a look at our Texas data. The rate of severe maternal morbidity, as defined by those ICD-10 codes, ICD-9 and 10 codes that I mentioned, is about 195 per 10,000 hospitalizations here in Texas. To compare that nationwide, the overall rate is 145 per 10,000 hospitalizations. So Texas is significantly greater than our peers. The most common of these is transfusion of 4 or more units of blood. This is followed by DIC, cardiac events that we've talked about as a leading cause of mortality here in Texas, and hysterectomy. In many cases, that hysterectomy is being performed in situations of obstetric hemorrhage. Eclampsia, also a significant complication. When we think about the hypertensive disorders of pregnancy and their complications, it's not limited to eclampsia. As many of you know, we can also see complications like acute respiratory distress syndrome, pulmonary edema, we can see acute renal failure, we can see hepatic injury, so there are a wide variety of complications that are associated with our hypertensive disorders of pregnancy. Just looking at our obstetric hemorrhage rates here by race and ethnicity, you can see that the rate of transfusion is significantly higher among African American women than it is for other ethnic groups, and that there has been a significant increase over time in the overall rate of hemorrhage as denoted by transfusion among all of our groups. Taking a look at the distribution of hemorrhage and the diagnosis of this severe maternal morbidity statewide, we have a plot here. The darker colors on this map represent areas with higher rates of hemorrhage than other states. The lighter rates, either some of the white boxes have no cases or fewer than 100 deliveries, and then the lighter colors represent lower rates of hemorrhage. It's important to remember that in small, less populous counties, a small change in the number of affected women can have a dramatic change in rate. If we were to do this plot again and look at the frequency of hemorrhage diagnoses, what you would see is that the frequency is concentrated in the areas with the highest volume. So the frequency is highest in our major metropolitan areas. Looking at hypertensive disorders. So the hospitalizations that we see with hypertension have significantly increased over time, and what we see is hypertensive hospitalizations more common for African American women than they are for women of other racial and ethnic groups. Again, we can look at this by our Texas geography. What we see here, again, is that plot of the areas with the highest rates of hospitalizations due to obstetric hypertension by county. Darker colors, again, representing those counties with higher rates. Lighter colors, either no deliveries or lower rates. Once again, if we were to plot this by frequency, you would see the same thing. Higher frequency in our major metropolitan areas where the majority of our women are delivering. And again, the good news. Let's think about the good news. Focus on the good news. So, maternal mortality, maternal morbidity is preventable. There is good data from other maternal mortality reviews that many of the obstetric deaths that we see are in fact preventable. It's estimated that about 60% of all obstetric deaths are in fact preventable. And you can see by cause, the rates of preventability vary for problems like hypertension, eclampsia, or preeclampsia. Virtually all of those deaths are considered to have at least some opportunity for prevention. Similarly, deaths due to obstetric hemorrhage or venous thromboembolism both have a significant chance of preventability. So it's important for us to remember that these complications, these maternal deaths, are preventable in many cases. We're incredibly fortunate to have here today Jean Mahoney from ACOG's National Office, who will be talking with us about some of these interventions that we can put into place that can really make an incredible difference. One of these interventions are AIM bundles. The National Council on Patient Safety in Women's Health is a group of 19 professional organizations and 2 patient organizations working collaboratively to put together collections of tools that can be implemented in communities and in hospitals to reduce complications, to reduce severe maternal morbidity and maternal mortality. These sets of evidence-based practices, when implemented consistently, have been demonstrated to significantly improve outcomes. They create a culture of patient safety. The teams, because of their interest, because of their desire to participate in the implementation of these bundles, change the culture in their hospitals, and that makes a profound difference. We can see data here illustrating the implementation of a hemorrhage bundle in a very large state with a demographic distribution similar to ours. With the intervention group, you can see baseline and follow-up. And what we see is a significant reduction in severe maternal morbidity due to hemorrhage in the hospitals who implemented these safety bundles compared to hospitals in the control group who did not implement the bundles. And again, one of the things I think that's incredibly important that speaks to the culture of safety that develops in these hospitals, the commitment to changing the culture, is that there was a significant reduction in all types of severe maternal morbidity with the implementation of the hemorrhage bundle. And finally, just one last piece about the severe maternal morbidity reduction with these AIM bundles. We've taken a look at 4 states that implemented these bundles a number of years ago, and they exhibited significant decreases, a 20% decrease in the rate of severe maternal morbidity after implementation of the bundle. So these bundles give us hope for the future that implementation of these types of evidence-based programs can really significantly change the rate of complications and mortality for women. Dr. Hellerstedt?
Thank you, Dr. Hollier. So I think you can see, first of all, I find the data very, very intriguing and very compelling. And as you can see, it is a complex problem that has many different causes. And so part of our challenge is to figure out what we can do to move the needle, if you will. Together, we will discuss this morning some public health initiatives that are underway and are needed to address this. So one of the first things is to increase the accuracy of our death certificates. We know that when we compare, for instance, the methodology that we had of looking at the confirmed deaths by matching a woman's death certificate to a birth certificate or a fetal death certificate, we know that there's a considerable number of death certificates when we go and look at the actual medical records where it was indicated the woman was pregnant, but there's no evidence in the medical records that they were pregnant. So there is a fundamental problem with the accuracy of death certificates. The pregnant or not pregnant is only one aspect of that, and so we're going to talk a little bit more about some initiatives going forward to increase the accuracy of death certificates, since that is one of the central means by which the maternal death rate is calculated. And of course, the methodology that was described earlier with the 4 years of data clumped together, we realize that that's sort of an incomplete way to compensate for the fact that the death certificate data itself isn't that accurate. We know that we're going to miss instances where there was a miscarriage prior to 20 weeks, but at the same time, it's also a way for us to say to ourselves, when we look at that data set of confirmed maternal deaths, we know what we're dealing with. We know that an error in the death certificate that incorrectly said that the woman was pregnant when she was not. So DSHS is committed to improving the accuracy reported on the death certificates, and the last session, the 85th legislative session, had a Rider 36 that called us to take action on that part. In fact, the action plan is a product of the Maternal Morbidity and Mortality Forum that was held in partnership with the TMA in September, and we're very grateful for the leadership and collaboration that took place there. So as far as the outreach and the accuracy of the death certificates, one is to have a focused outreach. We're soliciting through our partners just exactly who do we need to reach out to in terms of making these improvements. And we know that basically that's the folks who fill out death certificates, and that includes physicians, justices of the peace, and funeral directors. And the goal there is to learn about the specific challenges that those types of folks face in linking maternity or pregnancy status to the death certificate, and indeed overall accuracy in the underlying cause of death. I'll make a confession here. First of all, when I was in clinical practice, that was before we had the electronic system that we have today. But if I was taking care of a very sick kid in the hospital, let's say they succumbed to overwhelming sepsis, the terminal event might have been calling a code and doing CPR. If I was asked to fill out the death certificate for someone who was not resuscitated, I would have put cardiac arrest. That's not what we're looking for in terms of a death certificate. I didn't understand that. I was not educated to that. And so I personally think a big piece of this will be to provide that education. And so that's another initiative. We want to have some training and education materials. I've taken the one, for instance, for New York City. I think it's amazing. It doesn't take any longer period of time than the one we have for Texas. But in my experience anyway, comparing it to what we have here and what they have, it provided a much clearer understanding for the physician about what a death certificate is. And it's subtly yet profoundly different than the use of a clinical medical record. So one of the other things that we're looking forward to is in 2019, where we will be completing and implementing the Texas Electronic Vital Events Register, or what we call TexasAIM. And we are going to collaborate with funeral directors, justices of the peace, as I said, physicians, to ensure that this technology optimizes our ability to have accurate electronic death records. And for instance, with regard to pregnancy, we can build in there, if you will, kind of a validation step for the person filling out the death certificate. And TexasAIM, we know, will meet all of the applicable national and state statutory requirements for this kind of system. Maternal health and safety is also a top priority for our agency's Healthy Texas Mothers and Babies programs, or HTMB. Individual and public awareness and knowledge, professional education, community empowerment and improvement, and the Perinatal Quality Improvement Network are the core functions of the Healthy Texas Mothers and Babies program. I will focus on the first and last components, if you will, which will, we believe, will be most critical in improving maternal health and safety. First, through individual and public awareness and knowledge, the Healthy Texas Mothers and Babies increases knowledge to change attitudes and behaviors for improved maternal and infant health outcomes. This component emphasizes the importance of healthy living, obtaining timely prenatal care, and understanding the role of health disparities and the increased risk posed by chronic diseases such as obesity, diabetes, hypertension, and smoking. I found the data that we had on smoking as a risk to be especially noteworthy. DSHS plans to embrace its Someday Starts Now public health awareness campaign to include this important information for the general public, including women of childbearing age and their families. DSHS will also continue to work on expanding its preconception peer education program, moving from where we are now at historically black colleges across the state to include all the colleges and universities in the state. The goal of this program is to promote preconception health and healthy lifestyle behaviors to prevent chronic conditions such as obesity, diabetes, hypertension, and smoking that we saw the correlation between those risk factors and maternal morbidity and mortality. We will also continue to encourage primary care physicians to use the evidence-based one key question approach, basically by asking women between their pregnancies what their intentions are with regard to their reproductive health needs. The Perinatal Quality Improvement Network is equally critical in ensuring the maternal health and safety. The goal is to drive system changes to support adoption and diffusion of quality improvements in maternal and infant health and safety. And key maternal safety initiatives here include risk-appropriate maternal care, and as Dr. Hollier introduced to you, the implementation of the AIM, or the Alliance for Innovation in Maternal Health, maternal safety evidence-based practices, if you will. DSHS, as the public health authority, has a critical role to play in ensuring the risk-appropriate maternal care. Per the guidance outlined by ACOG, the goal is for pregnant women at high risk to receive care in facilities that are prepared to provide the required level of specialized care, thereby reducing maternal morbidity and mortality. The DSHS Consumer Protection Division is responsible for establishing the rules by which hospitals receive maternal levels of care designation. After September 1st of the year 2020, hospitals without maternal level of care designations will not receive Texas Medicaid reimbursement for maternal services. Also, DSHS Maternal and Child Health will be calculating maternal health outcome measures for ongoing monitoring and for redesignation every 3 years. Note that the risk-appropriate maternal care is consistent with House Bill 15 from the 83rd legislative session. As you can see here, the department is charged with establishing rules and criteria for designating maternal levels of care. Equally important for ensuring the maternal health and safety is the implementation of the AIM maternal safety practices. You will recall from Dr. Hollier that these practices are effective, evidence-based practices in reducing severe maternal morbidity and using evidence-based systems to enhance the care. We at DSHS are excited to announce the launch of TexasAIM, an initiative to improve maternal health and safety. TexasAIM will focus on implementing 3 of the evidence-based sets: obstetric hemorrhage, severe hypertension in pregnancy, and obstetric care for women with opioid use disorder, which is being developed and will be finalized soon. I'm proud to say that we were asked as Texas to be kind of on the group that developed the opioid practices guidelines. We recognize that, however, that the practice of medicine is the purview of physicians, and as such, enrollment of any of the hospitals, the medical staff, is completely voluntary, and there's no deadline to join. What we hope to do is to reach out to our colleagues in healthcare, our fellow physicians, if you will, and give them the evidence of how effective these AIM bundles are. Before I became commissioner, I was a physician executive at a hospital system here in Austin, and so I know very much from the folks, some of my former medical staff members and key leaders are in the room here, that once the physicians understand that this is something that will benefit their patients, they are eager to implement it. And in particular, Dr. Hollier mentioned, and I want to also stress, the fact that this is about training the whole team. And so one of the things that one of the models, if you will, that we learned about and learned from in healthcare in terms of improving outcomes and safety is the airline industry. And there, people were highly motivated to make sure that the plane landed safely, as you can imagine. And so one of the key things there is just having one member of the team. So imagine you got on an airplane and only the co-pilot knew what to do in an emergency. That would not be a good situation. And of course, the team approach to safety in the airline industry is something that we really have to understand the dynamic of how that works in healthcare as well. So these evidence-based sets are not just about what the doctor does or orders, it's about educating the whole team to recognize and then very appropriately and in a very timely manner respond to the emergency that they see at hand. So with the help of our partner organizations and stakeholders that make up our AIM implementation group, we're in the process of enrolling hospitals, and we're extremely happy to see the level of interest and participation that we have so far. As additional steps is needed, DSHS will be hosting an information webinar on March 28th. I think you have some information in your packet on that. And then a maternal safety needs assessment survey will be sent to the birthing hospitals in Texas. The webinar will provide an opportunity to gain better understanding of TexasAIM for folks who are interested, and the survey will help hospitals gauge their readiness for the AIM practices implementation. If you're interested in implementing AIM maternal safety practices and participating in the webinar, please send a message to the email address or visit the website that's listed. As note, the TexasAIM is consistent with Senate Bill 17 of the 85th Texas Legislature, which requires DSHS to implement a maternal health and safety initiative with a legislative progress report due on December 1st of this year. As Texas works towards maternal levels of care designations, the AIM safety bundles also offer an opportunity for hospitals to meet designation requirements, such as the implementation of a quality assessment and performance improvement program. DSHS also leads an interagency work group to ensure coordination of policy on maternal health issues, consistent with task force recommendations from our Maternal Morbidity and Mortality Task Force. The work group's goal is to ensure that women have access to prenatal and postpartum health that includes assessment and treatment of chronic diseases and behavioral health issues such as prenatal and postpartum depression and substance abuse. Central to this effort are the HHSC client programs. For instance, women's health services, such as Healthy Texas Women program, continue to offer a benefit package up to a year after delivery. They have streamlined enrollment, and they have extensive outreach. That program provides access to family planning services, as well as certain healthcare services, such as screening for and treatment of diabetes and hypertension. Screening and referral for postpartum depression is also available. In addition, HHSC administers the behavioral health services to prevent and treat opioid use in Texas, with a focus on pregnant and postpartum women. The new Texas Targeted Opioid Response, or TTOP, program at HHSC is aimed at preventing and treating prescription and illicit opioid abuse in high-risk populations, including pregnant and postpartum women. HHSC also administers behavioral health services for mothers and newborns affected by neonatal abstinence syndrome due to opioid use during pregnancy. In terms of Medicaid services, HHSC recently expanded its Medicaid substance use screening benefit to include screening, brief intervention, and referral to treatment, or SBIRT. SBIRT is an evidence-based approach to the delivery of early intervention and treatment services for persons with substance abuse disorders, as well as those who are at risk for developing such disorders. Medicaid also covers a comprehensive substance use disorder treatment benefit that includes pharmaceutical, outpatient, ambulatory, and residential treatment services. HHSC is also developing a tool kit as a resource for Texas clinicians for the screening, diagnosis, and treatment of postpartum depression. The toolkit includes coverage and reimbursement options for postpartum depression through Medicaid, CHIP, the Healthy Texas Women programs, and the Family Planning program. And that concludes my presentation. I want to thank you all very much. I want to thank especially Dr. Hollier for laying out the current state needs and the data in terms of the current status of maternal morbidity and mortality in the state. I want to thank Dr. Cardenas and TMA for the opportunity to provide you with an overview of this extremely important topic. And lastly, I want to thank you all as colleagues and partners for your continued work to improve the health of mothers in our great state.
We're running a little ahead. You want to do some questions?
Absolutely, sure.
Okay. So we're running ahead of schedule, and I think it would be a great opportunity to ask a few questions, some facts related to the data that was presented. And so there's microphones on both sides if you would like to ask any questions. Ernie?
year did the death certificates get accurate? When can we say the data looks pretty good?
So I think everyone heard, but if you didn't, when do we think that the death certificates can become accurate? Or when will we be able to trust the data?
Testing? All right. That's a great question. Time will tell, and I think we'll have to do some work to validate whether or not the kinds of new education in particular that we're going to provide actually increases the accuracy of the death certificate data. But we know, for instance, through studies that we have undertaken, that if we, like the task force does, if they go and actually look at the medical records where there's been an attribution of pregnancy and it's not accurate, or it can sometimes definitively show that the woman was not pregnant within a year prior to her death, we know that it's inaccurate on that basis. We have some sense of, in the case of maternal mortality, we have some sense of the magnitude of that. It's in a sense not a lot, but because of the total number of maternal deaths that there are, all that has to happen over the course of a year to drastically change the rate is for 30 or 50 errors to take place out of all of the out of all the deaths of women in the state of Texas. So we know that we can design a system, and a lot of high reliability is systems-based high reliability. So we hope that we can design a system for the death certificates that is much less prone to having human error propagate through to having inaccurate data. So that's a great question, Ernie, and we will need to test our hypotheses about how effective our new training will be in our new system.
Our next question, Dr. George Sade.
Good morning. Thank you so much for this wonderful presentation. I personally would like to qualify the AIM bundles as expert opinion based rather than evidence based. At least the way I look at the evidence, I don't think they qualify to be evidence based. It's expert opinion based.
Okay. Thank you, Dr. Sade, for your comment. Any thoughts?
I'm not an academic. My understanding is that there is good evidence that the AIM bundles work. Other states that have used them have driven down their maternal mortality rates demonstrably. Number one. Number two, they are there. Even if they are, if you will, expert opinion, the experts that we have consulted with believe that they're valid, they're clinically valid. So we don't want to waste any time in terms of moving the needle on maternal morbidity and mortality. And so AIM, we believe, has demonstrated its ability to reduce maternal morbidity and mortality, and so we're committed to going ahead.
Thank you, Dr. Hellerstedt. Another question?
I'm Laura Figapart from the Valley. Dr. Oli, my question was for you. On your slides, you presented that the diagnosis of maternal depression is higher, or depression period, is higher among white women, but the feelings of hopelessness and depression are higher among Black and Hispanic women. And have we gotten down to the granular level of data where we can say that these were women who were reporting feelings of hopelessness but maybe didn't have access to care to receive an appropriate diagnosis and then subsequent care? Or is it a diagnosis problem, or is it an access problem, or probably it's both? But
Laura, that's a great question. Unfortunately, we don't have the specific information that we need to be able to answer that question, but I think it illustrates an important point about perception and diagnosis and gives us an opportunity for further study.
do we have any data with regards to where they're seeking their care? Like, is it coming from an ER? Is it coming from a prenatal visit? Is it coming from a primary care doctor?
Yeah, I am not aware of that.
I'm not either.
Okay. Great, thanks. Dr. Curtin?
Doug Curran, rural doc in Athens, Texas. In our area, we're seeing a ton of hospitals dropping their obstetrical services. I have a lot of angst about that because those people are going to show up in the emergency rooms and other places and deliver their babies. They're not going to get prenatal care, and they may go to the city and get care, but they end up in our, OB area, and we've lost everybody around us. Kaufman up the road's closed, Rockport, all the other places, they're gone. It's us or Dallas, which is 120 miles away. So any looking at that, any ideas about why that's happening, anything we can do to facilitate continuing some element of local care, because it's going to be a problem if we don't. They're going, like I said, I think we're going to see them delivered in emergency rooms, and I just, it's a real lift for us out there in rural Texas to attend to these folks.
Thank you so much, Dr. Curran. The closure of obstetric services in rural areas is a problem that we're seeing nationwide, and it is definitely something of significant concern for the American College of Obstetricians and Gynecologists, and we're looking at different strategies to provide assistance to the physicians in these rural facilities. There are a number of programs that are being investigated. One of the current presidential task forces is looking at the use of telemedicine and whether that could be a potential solution to provide some support, but certainly other options will be necessary.
I couldn't answer any better than Dr. Hollier just did, so.
Okay. Please introduce yourself and.
Sure. Dan Crow with Superior. Very early in Dr. Hollier's slides, there was a slide about the mortality statistics, and if you looked at the causes of mortality, the things that were the highest incidence were substance use, suicide, and homicide, which are all related to societal things rather than medical things. Now, I'm wondering if you could speak to those things and how they relate to the social determinants of health and how important addressing those things are in relation to this.
Great question. Lisa?
Thank you for the question. I think I alluded a little bit to this when I was speaking. It is truly not possible for us in the 9 months of pregnancy to address all of the important things that happen to a woman that determine her health outcomes during that pregnancy. If we really need to transform the way we're thinking about health. We need to be thinking about health over the life course, and we need to be thinking about the factors that determine a woman's outcome really start when she's a fetus in the womb. And the social factors, where she lives, the school she goes to, the income of her family, the medical care that she's able to access as a child, whether or not her parents read to her. There are so many incredible things that affect a woman's ultimate outcomes, and we have to transform the way we're thinking about women's health. It can't be about that little sliver of pregnancy care. It needs to be about women's health over her entire life course.
And if I could add to that, very, very well said. To me, I mean, when we're looking at maternal mortality, we're looking at the tip of an iceberg. So under maternal mortality is maternal morbidity. And again, to me, one of the really eye-popping, if you will, statistics is the fact that for every maternal death, there's anywhere between 50 and 100 episodes of serious maternal morbidity. That's amazing. But then under that maternal morbidity, of course, is the health of that population of pregnant women. And underneath that is an even bigger pyramid that is the health of women of childbearing age. And as Dr. Hollier alluded to, underneath that is essentially the health of everyone in our society and the way we think about health. So, and if we look back again at many of these other problems, the obesity trends, I mean, it's really remarkable to me. Yes, there are disproportionalities, but to me, one of the other remarkable aspects of it is everyone is trending in a bad direction. All of society is trending in a bad direction when it comes to chronic disease It's nice to see smoking coming down, but that it just goes to show you how incredibly bad and poisonous smoking is, that can still be linked as one of the biggest factors in maternal mortality. So to me, again, that's a long way of saying it's ultimately about public and population health in the end.
Okay. We have time for just a couple more questions, well, these three, and try to get through these questions, and then we'll need to go to the next presentation.
Hi, I'm Tony Dunn. I'm from Waco, Texas, and I work for Dr. Hollier at ACOG. Are we separately tracking alcohol use disorders? And the reason I ask is because, of course, it's intimately involved in so many other aspects of suicide, intimate partner violence, and so forth that are major determinants of maternal mortality. Are we tracking that separately?
I can speak to the detailed case reviews. Within those detailed case reviews, yes, Tony, we sure are. We're tracking all of the factors that we believe to be contributing to maternal mortality. Do you want to talk about state data?
Yeah, let me talk a little bit about state data. I think that's a great question. One of my, if you will, primary goals for the Department of State Health Services is that we become much more adept at using the data that we have. So, for example, that question and other questions about where do people seek care, all those kinds of things, it may be possible that the data that we have can be understood and interpreted and analyzed in a way that gives us answers to those questions. But so we need to work on that. So one of the things that I've done is create an Office of Science and Population Health, and one of the key goals for that office is to have a physician who works intimately with our data analytics teams to understand what's in that data and how do you analyze it and look at it in a way that gives us meaningful, if you will, medically sound, clinically sound, actionable information. So these questions are great questions. In order to produce them takes an enormous effort to sort through and do all that data analytics. Over time, we hope to get there and get better at it.
Okay. Les?
Thanks, David. One person who's been exposed to talking about adverse childhood experiences, you might wonder if you looked at those 382 deaths, what was the exposure rate to adverse childhood experiences? And as was pointed out, the highest part of the death rates are these that you might expect to be included in that. So you kind of wonder if we had that as one of the screening tools or something similar to that, and you did that at the time of presenting for prenatal care, would we be able to better risk stratify those who might be more prone to these mortalities and morbidity?
As a pediatrician, the relationship between adverse childhood events and future health and outcome is profound and deeply moving. So I think that there's an applicability for understanding ACEs, if you will, adverse childhood events, in the context of the entire population's health. So I think that's a good point.
Okay.
Hi, I'm Akanamani, UT Southwestern Parkland Hospital. Dr. Hollier, when you put that slide up, it jolted my memory. So a highly informative slide. However, I'm looking at the other category that comprises almost 20% of your mortality number, which is similar to your drug overuse. I wonder if there are any specific major player in that other category that we can address as well.
Thank you for that important question. This information is derived from our death certificates. One of the important roles of the task force is to do a detailed review of the medical records of these women so that we can identify the causes and the contributing factors and be able to assign pregnancy relatedness. So the detailed reviews that the task force is doing are supplementing the information that we have here so that we can get that more detailed, better picture.
All right. Great questions, great presentations, and so please join me in thanking Dr. Lisa Hollier and our Commissioner of Health, John Hellerstedt, for their presentations.